Welcome to PlayPosit. We're going to be using this online platform throughout the class for select chapters. And what it does is it takes our lecture that we have and it allows us to create questions throughout it to make it interactive. So it's not just watching a lecture, but you're participating as you're going through the subject. So today we are covering Chapter 5, Medical Terminology. And before we get started, I want to talk a little bit about the importance of it. Because in class, it's very easy to use simple terms. And I am just as guilty as the instructor of using simple terms instead of medical terminology. But Ruth and I have talked with some of our former EMT students, and we asked them, when they took the national exam, what did they find they struggled with? What do we need to cover better? And medical terminology was one of those subjects. They said, we just didn't use it enough to become proficient. So from this point forward in class, if you can use medical terminology instead of simple terms, we want you using medical terminology. That's going to apply in your skills lab. That's going to apply in your homework. We want to see you using medical terminology. So to start, we're going to break it down into 3 sections. We're going to talk about medical terminology and how it's constructed. We'll go over a little bit of A&P, so our anatomy, physiology. And then we're going to talk about some anatomic terms that you are expected to know in regards to them being directional or positional terms. So to begin learning the language of medical professionals, we're going to start with a couple of basic concepts, and we're going to build from there. So to start, we need to talk about the 2 categories that our medical terms are going to fall into. The first one is euonyms, which are words that honor a person who first discovered or described that medical term. All right. Real common one, Achilles tendon. If you've heard of the Greek mythological character Achilles, he fought in the Trojan War and was considered undefeatable, except for when he was shot by Paris in his heel, and that tendon where he was shot is now known as the Achilles tendon. And that was how he was defeated in the end. But just an example of a eunonym. The other category is descriptive terms. And descriptive terms are that they describe, whether it's shape, size, color, function. They tell us about that word. So to explain how to understand those descriptive medical terminologies, we're going to watch this video with Chance because he does a really good job of breaking down how to read and understand those medical terms that we're going to be using throughout class. Now that we know how to read a medical term, we're going to practice it. So if you don't have your textbooks, get them out, log in online. We're going to refer to page 105 in the paper copies. Otherwise, on the ebooks, you can type in the search bar. We're going to go to table 5.1, and that's going to give us some guidance in answering these next couple of questions. In class, we will frequently refer to abbreviations and acronyms for the purpose of shortening a word or phrase or to assist us in recalling a series of words or phrases. The difference between the 2 is how they're pronounced. An acronym is sounded out, CPAP. An abbreviation is spelled out, DNR. Otherwise, they are essentially the same purpose. It is important to know when to use an acronym or abbreviation and when not to use it. In the back of the ambulance, when we're using CPAP, which, if you're not familiar, is an oxygen delivery device, we're going to ask for CPAP. We're going to call it CPAP. You're talking to the patient, if they have it at home, they probably also call it CPAP. It's a lot shorter than asking for the continuous positive airway pressure device. On the other hand, there are times when we're not going to use an abbreviation or acronym. If I'm talking to my patient, and this is a term from EMR, I'm not going to walk up and say, hey, can you tell me what your OPQRST is? Because they're not going to know what OPQRST is. However, if I walk up and start asking questions like, can you tell me when these symptoms started? That the patient is going to understand. So know when to use and when not to use your abbreviations and acronyms. And if you use OPQRST to ask a question in a skills lab, I guarantee your instructor should look at you and say, what? And they're trying to prompt you to ask questions. We know what it means. We want you to ask questions because your patient in the field, they aren't going to know what it means. So we have to push you to ask those questions. As far as your documentation goes, there is a list of approved abbreviations in the back of your SOP book. If you look through there, you'll find them. There's 2 pages. And these are what we're going to allow you to use in this class. So if you're doing homework, if you're documenting in class, you want to use an abbreviation. If it is on this chart, you can use it. If it is not on this chart, you cannot use it. Because we need to make sure that we're consistent in the message that we're giving. All right, some people are going to understand one abbreviation as one term and that same abbreviation as another term. All right, it's a lot like, is it potato or potato? LOC, is it loss of consciousness or level of consciousness? 2 different meanings, same abbreviation. So we use the approved abbreviations in our SOP book. So I want to give you a scenario of a patient that has chest pain, and you're responding to it as an ALS crew, so a paramedic with an EMT. And you guys get there, you put the 12 lead on, partner reads the 12 lead, and they tell the patient, we have ST elevation in leads 2, 3, AVF. We have reciprocal changes in 1, AVL, V5, and V6. Now, I want you to, in simple terms, tell me what was just told to the patient. Once I look at your answers, I'm going to guess that most of you did not know what ST elevation and reciprocal changes were. And that's okay. Because running a 12 lead, putting those stickers on, actually running it, that is part of our EMT scope of practice. Reading it, that's part of the paramedic scope of practice. So just like I wouldn't expect the EMT to know what ST elevation and reciprocal changes is, I would not expect my patient to understand what those terms were as well. So we need to make sure that we talk to the appropriate people in the appropriate terminology. So medical professionals, we talk to them in medical terminology. For our patients and their friends and families, we use simple terms. Because if they don't understand what we're talking about, they can't make an informed decision about going to the hospital. So instead of telling my patient they have ST elevation with reciprocal changes, I would probably tell them, based on the picture we've taken of your heart, we're concerned that you have a blockage preventing blood flow, causing you to have your present discomfort, and we recommend that you get transported to the hospital. Now, telling you that, you can make a much better informed decision than you could when I told you that you had ST elevation and reciprocal changes. So along with understanding medical terminology, we also have to understand anatomy and physiology. The next chapter that you go over on A&P is going to go much further in depth. But here, we're going to cover the basics and why it's important. Understanding anatomy and physiology is going to help you better assess and treat your patient appropriately. Because if you know where things are located and you know how they're supposed to function, you're going to be able to ask the right questions to figure out what's going on when we get to that medical and trauma assessments. So I'm going to give you a scenario. We have a patient that's complaining of chest pain. And when we get there, we need to figure out what's going on. Because anyone that works in the fire service knows that just because you got dispatched to the scene for chest pain does not mean it's chest pain. So you get there and your patient says, "Oh, I have had this chest pain. It is terrible." All right, so first thing you want to do, get that 12 lead. Because chest pain says cardiac to me. So we're going to expose our patient's chest, throw on that 12 lead, and we're going to run it. Guess what? It's sinus rhythm. We have a normal sinus rhythm. So probably not chest pain. We need to figure out what else could be causing this. Well, we have our patient exposed. So I'm looking. I don't see any signs of trauma. Maybe I should ask the patient. So I ask them if they've had any recent trauma, and they say no. Okay, so I know it's not cardiac. I know it's not trauma. I start thinking about my A&P, and I go, you know what? That digestive tract, it runs right behind the heart. Let's ask some of those questions. So we ask, hey, have you been nauseous, vomiting? No. All right. What about having normal bowel movements? And your patient goes, you know what? I've had some really dark, tarry-looking stool passing. And that clues you in. If you're familiar with your anatomy and physiology, you know that that digestive tract is right behind the cardiovascular system. And oftentimes, patients can mistake epigastric pain as chest pain, and vice versa. Patients with a history of having GI distress may not recognize that they're actually having cardiac event going on because they're so close, your patient can't differentiate between the two. But what my patient assessment has told me, they have dark tarry stool. That says, hey, they're bleeding in their GI tract because they're pooping it out. So I have to think back to what I learned. Well, it's not bright red, so I know it's not lower GI because it went through the digestive tract. So I have an upper GI bleed. Now, if I hadn't asked those questions and I started treating my patient for that chest pain and I gave him aspirin and I gave him nitro, guess what? I just made that upper GI bleed a lot worse than it had to be. So it's important that we don't just assume what we get dispatched for is what we're treating. Make sure you ask the questions. Know your anatomy, know your physiology, because it's going to help you assess and choose the right course of treatment. This last section of the chapter we have is anatomic terms. All right, there are a few terms here that you need to know for this class. The first term is anatomical position. This is a standard point of reference for all medical professionals. The anatomical position has your patient facing forward, hands at their side, palms facing forward. And whenever we're talking about a patient's right and left, it is always their right and left. So if I'm looking at my patient and their injury is on my right side, that would be the patient's left side. So make sure that you're referring to their right and left when you're describing any injury or medical condition. Next, we have the midline. This is an imaginary vertical line used to divide the body into right and left halves. In reference to the midline, we have medial and lateral. Medial being towards the midline of the body, lateral being away from the midline of the body. Our next two terms, we have unilateral and bilateral. If we were to break these terms down, our root, lateral, that tells us side. Our prefix, uni, bi. Uni is 1, bi is 2. So unilateral, one side, bilateral, two sides. Our third term here, mid-axillary line, just like our midline, which was an imaginary line that split our body into front or left and right, the mid-axillary is an imaginary line that runs down our armpit, and it splits the body into front and back. Talking about front and back, we have anterior, posterior, also known as ventral and dorsal. All right. I would, for the most part in class, I would say we mostly use anterior, posterior. But I do know the national exam has in the past used the terms ventral and dorsal. So I would make sure you're familiar with them so that if you see them, you recognize them. But I will be honest, we mostly use anterior, posterior. Anterior being the front of the body, posterior being the back. Ventral being the front of the body, dorsal being the back. If you think of where a dorsal fin is on a shark, it's on their back, that's dorsal. Next, we have superior and inferior. All right, superior being towards the top of the head, inferior toward the feet. Proximal and distal. Proximal is usually closer to the torso, distal being farther from the torso. This photo shows the different body regions. So we have our head, which would be everything from the face, cranium. We have our torso, which includes the thorax and the abdomen and pelvis. And we have lower extremities, which is everything below the pelvis. We have upper extremities are from the shoulder to the hand. This slide just groups all of those terms we just talked about into one slide. The only thing that is new on this one would be midclavicular. So if you're looking at the anatomical position photo and you're on the patient's left side, top term, it says midclavicular. Well, if you follow that line over, you're going to notice that there's 2 points on his clavicle, so midclavicular, and just like your midline, it has an imaginary line that goes down towards the ground. All right, and if you're using it in conjunction to the midline, it breaks the body into 4 sections. Planes of the body, we don't refer to this too often, but there may be a national question on it, so you do need to be familiar with it. But we have our frontal plane, sagittal plane, and transverse plane. Our abdominal quadrants. You are going to be expected to know this. We have an imaginary line that goes through our belly button, perpendicular. So we have our midline that goes through our belly button vertically. And then we have what would be that transverse plane, comes through it perpendicular to that midline. All right, right through that belly button. And it divides our abdomen into 4 quadrants, right and left, upper and lower. You are expected to know the organs that fall within each of the quadrants. So here are our first 2 positional terms. We have supine and prone. Supine, your patient is laying on their back, face up. I remember supine is on their spine. This is going to probably be the most common position that you're going to have your patients in. On the flip side, we have prone, which is your patient laying face down on the ground. Sometimes their head will be to the side. And then in between those 2, we have our recovery position, which is also known as a lateral recumbent position. So if you remember, lateral means side, means your patient's on their side. And usually we use the terms right lateral or left lateral recumbent. And all it does is it tells you what side they're laying on. If I'm laying, my left side's on the ground, it would be a left lateral recumbent. This is kind of that in between your supine and prone position, because if we had them in the prone position, they could suffocate if they were face down. And then if we have them on their spine and they're unresponsive, a lot of times their tongue will fall in the back of their throat, which we're going to cover in airway. Number one airway obstruction is your tongue. So we don't want them in that position either. So we roll them into the lateral recumbent or recovery position. When we're transporting our patients, we have to document what position we have them in. Were they sitting? Were they in a semi-Fowler's, Trendelenburg position? It's relevant to the care that we're providing. We don't have it listed here. I don't think it's in your textbooks either, but full Fowler's would be your patient sitting up at a 90-degree angle. Semi-Fowler's is between 30 and 60 degrees. And then Trendelenburg would be laying on their supine with their feet elevated. So I remember Trendelenburg, toes to the ceiling. Your toes are elevated. That was a lot of information to cover in a very short time. So if you need to, I highly recommend go back, rewatch this, make sure you brush up on areas that you need extra assistance, because medicine is a language of its own, and it is not easy to learn. It takes practice and repetition. So we need to be using these terms when we're doing our homework. We need to be using these terms when we're in the classroom so that we learn how to speak the new language. So like I said, in class, we're going to practice and we're going to make sure our medical terms are accurate and descriptive, so that when we're done with class and we're working in the field, we can appropriately communicate with other medical professionals. And knowing that A and P of your patient, that is going to help you better take care of your patients. To wrap up this chapter, we have a scenario for you. You respond to a teenage boy who has taken a hard fall from his dirt bike. He has a deep gash on the outside of his left arm, halfway between his shoulder and his elbow. Another on the inside of his right arm, just above his wrist. His left leg is bent at a funny angle, about halfway between his hip and his knee. When you cut away his pant leg, you see bones sticking out of a wound on the front side. How will you describe your patient's injuries over the radio to the hospital staff? So that's the last question. Once you answer that, you guys are done with this Play-Pause-It interactive assignment. Your participation points will be based on your participation, not your grade of what you got on the assignment. This is a learning assignment, and as such, we want you to learn from it. So if your answers are wrong, that's okay. However, don't be putting in just blank answers, making things up, because if you don't look like you know it, we're going to reach out to you. All right, because we want to make sure that everyone is comfortable with medical terminology. If you have questions, please don't hesitate to ask us. All right, thanks.